So good afternoon, welcome everyone, and thank you for your active participation to this webinar. This webinar really represents the focal point of a multi-year project called Therapeutic Adherence during the COVID-19 pandemic across Europe. Impact, experiences, and perspective from patient advocacy group and relevant stakeholders. And today we have the opportunity to share the outcomes of the activities with a wider and multidisciplinary audience. The webinar is organized in the context of the European Patients' Right Cross-Border Healthcare with the unconditional support of IATRIS. So we see now in the past years, we experience how COVID-19 has changed people's routines and somehow it imposed new ways of living, and our restricted access to the medical services dramatically impacted the mortality and the morbidity associated with chronic conditions. At the start of the pandemic, there was a global focus on monitoring and controlling infection rates, which had an immediate knock-on effect on NCD patients, and in particularly, I would say, on older and more vulnerable individuals. The routine care of patients was, in a way, severely disrupted, and still today, there is a growing concern about the long-term impact on the clinical, social, economical, and psychological outcomes on NCD patients. Multi-institutional partnership, such as this one, can really help to identify innovative tools to address patients' needs and somehow push to increase awareness both among healthcare professionals and general population. It's really time to deep dive into the core of the webinar. And for that, let me introduce, for the welcome address, Mariano Botta, Director of the Active Citizenship Network, and Sabrina Pignedoli, Member of the European Parliament. Mariano, stage is yours.
Grazie Alessandro. Good afternoon also from my side. Welcome to this European webinar, which is an integral part of our, we can say, busy calendar of appointment that Active Citizenship Network has made this month, with initiative also on the topic of medical desert, clinical trials, participation in public events to bring the civic perspective on public policy related on vaccination and antimicrobial resistance. Today, the topic is probably one of the main victims, we can say, of the COVID-19 pandemic, that is the adherence to treatment. In a couple of years, as we know, over 20% of the Europeans will be 65 or older. We know by now that the fundamental condition for active and healthy aging include not only prevention, adoption, healthy lifestyles, but also adherence to medical treatment and pharmaceutical prescriptions. Among patients with chronic illness, approximately 50% do not take medications as prescribed. This high level of non-adherence results in higher healthcare costs, lower quality of life, and poorer health outcomes, which make this phenomenon a major concern for public health. It is estimated that each year the poor adherence to medication in Europe causes about 200,000 deaths and burden on health expenditure up to 80 billion euros. These data were collected before to the COVID-19 pandemic, which has only worsened the already critical situation, triggering multiple problems for individuals suffering from non-communicable diseases and chronic condition in general. Poor medication adherence to therapies treating non-communicable diseases especially increased because of the pandemic-related circumstances, including lack of medications, reduced access to pharmacies, and a decrease in healthcare professional services for medication control and adjustment. Indirectly, the negative impact has affected the national healthcare system as a whole, including more outpatient visits, higher use of healthcare costs, among others. Also, for this reason, we have appreciated that the European Commission has launched, you can say, little more than 1 year ago, the Healthier Together European Union Non-Communicable Disease Initiative to support European countries in identifying and implementing effective policy and action to reduce the burden of major non-communicable disease and improve citizens' health and well-being. The initiative covers the next 5 years and include 5 strands: health determinants, cardiovascular disease, diabetes, chronic respiratory disease, mental health, neurological disorders. All strands include an healthy equity dimension, thus supporting the reduction of health inequalities, and we hope a greater investment on the value and the management of a therapeutic adherence. On this topic, my association, Cittadinanza Attiva, has been very active for years, both at the national and also at the European level through our European branch, Active Citizenship Network. For example, a few months ago in Italy, we presented data. According to our civic survey conducted at the national level in Italy on patients with cardiovascular disease, only 30% of them believe that their physician, specialist, or general practitioner has spent the right amount of time explaining the treatment pathways and the importance of systematic and consistent adherence to it. In July, we have also presented an action plan to therapeutic adherence from regional analysis to national plan, realized by my organization with patient association, scientific society, regional institutions, which brings together analysis and proposal. Among this proposal, the measuring therapeutic adherence, developing and implementing a standardized model to personalize the approach to care, identifying therapeutic choice also based on age, social, economic, and residence factors in order to reduce any discrimination in the delivery of services. Focus on pharmacy, community nurses, caregivers as a pillar, as central figures for improving health performance of citizens, starting from the most vulnerable and for greater therapeutic adherence. Increase medicine and digitalization in order to reduce critical access to services and better monitor the care pathways. Debureaucratize, to reduce bureaucracy processes, especially with regard to the renewal of treatment plans. At the same time, at the European level, we have conducted a survey that will be shortly presented by my colleague Bianca, who coordinated the work, a survey that was made possible thanks to the collaboration of 38 associations linked to our network, association that, of course, I want to thank. Without anticipating anything, I only say that the data and recommendations collected show us the inadequate attention of institutions and the main stakeholders in relation to access and continuity of care for non-COVID-19 patients. From here, we will start to better understand how to strengthen treatment adherence, an indispensable element in aiming resilient health system services towards to build a European Health Union. For our part, we are convinced that therapeutic adherence does not only mean that patients take their medications correctly for the necessary time, but also implies the ability of the national health system, to identify and modify unhealthy behaviors and habits of patients to ensure access to benefit and services in a timely manner that is appropriate to the care needs of citizens, and to involve, this is relevant for us, patients and caregivers in the care pathways. In this sense, therapeutic adherence is the result of the alliance between the patients and all the health professionals who have taken care of them and who accompany them through the different stage of the care process. In short, moving from therapeutic adherence to therapeutic alliance. And on this point, I will be pleased to hear from the speakers, whom I thank in advance, and I thank today's moderator, Alessandro Monaco, experienced healthcare manager and consultant, the right person to chair this event. So thank you for your attention. I wish you an interesting webinar, and I give Alessandro the floor again.
Thank you very much, Mariano. I would like probably for the video message from Sabrina Pignedoli, a member of the European Parliament.
La ricerca condotta da Cittadinanza Attiva ha svelato come in Europa, durante l'emergenza del Covid-19, ci sia stata una crisi parallela e meno visibile di quella enorme provocata dalla pandemia. È quella che ha interessato milioni di pazienti cronici in tutti i paesi dell'Unione Europea. Con l'esplosione della crisi abbiamo tutti sottolineato l'importanza di dotarci di una politica sanitaria più coesa a livello europeo, in particolare per fronteggiare emergenze del genere, ma dovremmo anche capire che cosa non ha funzionato a livello più globale nel settore sanitario. Tutti abbiamo seguito la carenza dei posti letto negli ospedali per i casi più gravi di Covid-19, ma non sappiamo bene cosa sia accaduto a un paziente cardiopatico che non riusciva a prenotare una visita specialistica o a farsi visitare dal proprio medico di base, oppure che per il rischio di contrarre il Covid ha deciso di non farsi visitare. Il rapporto ha sottolineato anche un altro genere di problema, per esempio la difficoltà di reperire i farmaci da parte dei pazienti cronici. La sanità è di competenza nazionale, ma l'Unione Europea deve intervenire di più con delle linee guida che possano sviluppare e innovare alcuni settori. Prima di tutto sarebbe urgente intervenire per migliorare la comunicazione tra medici, strutture ospedaliere e pazienti. Una comunicazione che riguarda tanto gli specialisti quanto i medici di base. L'uso di risorse elettroniche, del web, può essere sviluppato. Anche la telemedicina potrebbe aiutare a coadiuvare le visite in presenza. Molte persone si sono attrezzate a casa con strumenti che fino a qualche anno fa trovavano solo in uno studio medico. Basti pensare al saturimetro o al misuratore della pressione arteriosa. La telemedicina si è sviluppata notevolmente e può essere molto utile per seguire i pazienti a casa. Nel programma della Commissione europea EU4Health per il 2021-2027 i 4 pilastri sono prevenzione delle malattie, preparazione alla crisi, sistemi sanitari e personale sanitario e digitale. Sulle risorse e la formazione che riguardano il digitale e il personale sanitario si giocherà la resilienza futura dei nostri sistemi sanitari. Tra il personale sanitario, va sottolineato, non ci sono solo i medici, ma anche i farmacisti e gli infermieri, che hanno avuto un ruolo così essenziale anche durante la pandemia e il cui ruolo va salvaguardato con politiche e risorse europee adeguate.
Well, thank you very much, Sabrina and Mariano, for, I will say, probably address the current scenario from the wider institutional perspective and identifying what didn't work and how to prevent it from next situation. It's probably the best step we can do to avoid that these disruptive events can happen again. And now I would like to introduce Bianca Ferraiolo, the head of the representative office of the EU of Active Citizenship Network, that will share with us the key insight from the study in collaboration with the Patients Association from all over Europe. Bianca, stage is yours.
Very much. So let me share my screen. Why I can't see it? Just a second. Technical issues as always. Okay, no. Yes. Okay. Yeah. Can you see it? Yes. Okay, great. So thanks again. And as anticipated, the survey that I'm going to present you in a moment was conducted in involving 38 patient associations from 18 countries, mostly European, but also some from outside the EU, including, not surprisingly, Israel, a country that during the pandemic was observed with particular attention for how it was dealing with the health emergency. And that is why you will also find in the slides the reference to Israel, which, however, during today's presentation, I will not emphasize for reasons of time. Here are the logos of the associations that participated in the survey, which are part of our network and which I also thank for their contribution. Among the respondents, the vast majority held an executive role in the association. And here you see that the 35% of the associations that participated are patient-led associations, 29% are patient advocacy groups, and the rest is represented by civil society associations and associations of professionals in touch with patients. Most of the associations are those that, not surprisingly, are related to chronic diseases, but also rare diseases. And then there are associations focused on protecting patients' rights, regardless their type of pathology, such as Cittadinanza Attiva, of which I would like to recall that ASEAN represents the European branch. Here you see the details of the pathologies from which the represented patients are most affected. And as you also see, the most numerous are chronic pathologies. For the sake of clarity, I would like to point out that, as you can see, the sum of these numbers is much greater than 38, because of course, among those that responded, there are associations that deal with several different pathologies. Most of the responding associations work at the national level, but again, there are some that work like Cittadinanza Attiva at the national and or local and European international level. Now, let's see what the associations that participated in the survey responded, and let's get into the content. So the top 5 of the main objective difficulties faced by patients during the COVID-19 pandemic show that these were getting an appointment with a specialist, but also communicating with specialists for urgent visits and updating their therapeutic plans, but also communicating regularly with their GPs and accessing emergency centers. The other question we asked was about medicines availability, which, as we know, was one of the side problems of the pandemic. And the patients represented by the responding associations reported as the 5 most common problems that patients didn't want to go to the pharmacy due to COVID-19 risk. But also it was not possible sometimes to get a prescription, and sometimes also patients could not go to the pharmacy due to health reasons. But also financial reasons were also among the most common problems. Or pharmacies were too busy or had too long queues. This last information actually underlines what we also observed in Italy, which is that during the first wave of the pandemic, pharmacies ensured continuous access to the National Health Service. And so when other doors remained closed, those of pharmacies remained open. The major concerns, regardless of the objective obstacles, emphasizing the subjective aspect and the patient's perception of the situation, were found to be the impact of the pandemic on one's own pathology, but also being in hospital or having an operation, and the repercussions on their mental well-being, but also having trouble continuing their ongoing care or treatment, and the poor access to regular lab and diagnostic testing for their conditions, but also the difficulty of access to home care professionals as well to GPs and specialists. So in addition to the main answers I have just told you, these are the other situations that emerged. Then we tried to get into the issue of therapeutic adherence and the impact of the pandemic on it. And forcing a little, we could say that according to the associations, in 1 out of 2 cases, the pandemic made patients less adherent to treatment. And in the majority of cases, the concerns cover the entire duration of the pandemic. Indeed, in the 52% of the cases, there was less adherence to treatment for both objective and subjective causes, as mentioned earlier. So these answers made clear that the impact on mental well-being has been very significant, especially for the fear of tomorrow and apathy. When we asked whether there was an increased use of generics, we did not receive particularly significant responses, and this can be interpreted in various ways. It appears from the answers that these are still little known and that there may be still be mistrust. Moreover, it is not always possible for the therapy to be substituted, and sometimes it is the doctors themselves who advise against the use of generics. So the people, and in this case, the people who have used generics the most have done so mainly for economic reasons. Here you can see how it emerged that nurses, family and friends, patient associations, and pharmacies were the figures who most helped patients to adhere to their therapies. And here again, the fundamental role of pharmacists in ensuring access to care and adherence to treatment during the pandemic is highlighted. We also then explored the level of knowledge of the concept of dose dispensing, and it emerged that although potentially useful for the purposes of increasing adherence to treatment, it is still poorly understood. So, given this scenario, let's see what actions and reactions have been put in place by the institutions and the relevant stakeholders to mitigate the effect of the pandemic on therapeutic adherence. The general picture highlighted an inadequate attention of the institutions and the main stakeholders in relation to access, continuity, and adherence to therapies for non-COVID-19 patients. Furthermore, in most cases in which activities has been undertaken, these have been carried out most of the time without involving the patient associations. At the same time, only 31% of the respondents to the survey said that they had actively done something to develop a therapeutic adherence strategy. And luckily, there is a moderate increase in the initiatives and good practices that exploit innovative and digital health solutions to promote adherence to therapies. Among these emerged information campaigns and webinars on digital solutions, but also apps and digital tools development and digital health projects, and the incentivization of electronic prescription use. The full version of the presentation and the results of the survey I have just presented to you will be made available in a few days, together with all the other materials on our website. And thank you again for your attention, and I leave the floor to the moderator.
Well, thank you very much, Bianca, for highlighting the importance of the direct involvement of patients and professional stakeholders association to collect, I would say, critical insight, data, objective evidence that should be used with a longitudinal approach for the decisional process, as well to design strategy to address individual needs. I would say that we should move now to the roundtable discussion, where the topic of adherence in the context of COVID-19 pandemic will be further elaborated from a different perspective, and real-world experience will be shared from our panelists. This, I think, will be a critical step to show and address the complexities of the phenomenon and how an important and holistic and multidisciplinary approach is needed to address the needs of the patients. I haven't seen many opportunities to gather such an influential panel of experts. Please let me introduce Dr. Bente Mikkelsen, Director of the Non-Communicable Disease in the Division of UHC, Communicable and Non-Communicable Disease, WHO. Neda Mileska-Kostova, Board Vice Chair, International Alliance of Patients Organizations. Dr. Andrea Manfrin, Faculty Director of Research and Innovation and Chair Professor of Pharmacy, University of Central Lancashire. Nick Galdemont, Professor of Healthcare and Public Health, Department of Public Health of Primary Care of Leiden University Medical Center. And Shantanu Donde, Head of Portfolio Management for Viatris. I will start with Dr. Bente Mikkelsen. First of all, I would like to thank you very much for joining us today. And we really would love to discuss with you the top priorities of WHO in addressing the key needs of NCD patients, in particularly during the pandemic.
Thank you very much, and I'm very pleased to be invited to this panel, and congratulations with the presentation. It shows the power of really inviting people affected by and living with the diseases. I think that is a learning point that we have all attended to after COVID. So you probably know that we have done specific work during COVID also on the NCD side. It was not obvious because, of course, we saw that everybody was looking into the virus and were thinking about communicable diseases. But early in 2020, it was very clear. We had phone calls from healthcare workers, from patients themselves, and from families really waving the red flag and saying that something bad is really happening beyond the virus as well. So until actually the autumn 2022, we could see that we had a 50 to 60% disruption from healthcare system for cardiovascular diseases, for asthma, chronic respiratory diseases, for cancer, and also, unfortunately, up to 33% for myocardial infarction and emergencies. So, and this was then 2 years into the pandemic. And we know also, even if we don't have the granular figures, that the excess mortality that has been recorded by WHO, which is almost 3 times the mortality that was expected, is very often due to non-communicable diseases. And as you said, moderator, I am a director for non-communicable diseases, but I won't shy away from actually focusing on them because they represent, even before any pandemic, 74% of all global deaths, and also an 80–90% of all burden in primary healthcare facilities and in first-level referral hospitals. So I will continue to say that, you know, what we saw during COVID is a syndemic. We really saw the lack of investment for the systemic approach for the health system to respond to chronic diseases and non-communicable diseases in general. Of course, some of the European countries is better placed than the really low and middle income countries in the rest of the world. But we still see, and you saw even in Italy, that because we haven't really included to the extent that we need the health system to be prepared, including on the medicine side, we haven't been really well prepared. So in a sense, we summarize this to say that we had a syndemic where people living with NCD was actually the ones dying most and also at highest risk for becoming very ill. But it was also a lack of diagnosis, which we now see as a backlog, a lack of treatment, which we also need to address. And we saw also the effect on the medicine market and the dependency the whole of Europe and the whole of the Western part of the world was on some of the other bigger countries. And we saw the unprotected health. And we saw that, unfortunately, industry engaged in tobacco and alcohol was pushing their unhealthy products in a very different way through the digital solutions coming up during COVID. And of course, the reduction in physical activity, all of these also impacted. Difficult to say exactly how much, but for sure. I will end up with 3 things. As was already presented by Bianca, it was amazing to see the mitigation strategies that countries were engaging in to actually mitigate the situation. And one of the things that was very obvious was that this was triggered very much by NGOs, civil society, and unexpected partners, I would say. So the latest mitigation sort of table, I can share this with you afterwards, was the community communication was one of the main mitigation strategies. Then triaging at the primary healthcare or community healthcare level, which means that we need to think about emergency in a different way. It's not a very advanced one, it's really the community health worker. And then, of course, the recruitment of additional staff, but among the most important thing was digital health and telemedicine, and provision of medicines that was not health system related. So new procurement mechanism, new sort of referral mechanism came out of this. You could look to India, for example, where they did this at scale. So my last comment is that I think what we see growing now in WHO and I would say all over the world is the interest for behavioral insights, not as an individual measure, but actually taking a systemic approach and calling on other academic disciplines than medicine, but also than technology, and really thinking how could social sciences help us to not only discover and innovate, but also to sustain innovation. I'll stop there. Thank you.
Thank you very much, Dr. Mikkelsen, for this very comprehensive perspective, institutional perspective on the topic. And you probably mentioned and introduced some of the topics that will be discussed also later, and also now with Dr. Milevska Kostova. So many of the efforts in that specific period has been focused on the technical part of the problem, right? On the how do you manage the patient and so on. But truly, much of it was about how the many social and psychological aspects were triggered by this emergency. For instance, the psychological impact of being restricted in small areas, as well as, for example, the interaction and the relationship with between patients and the healthcare professionals. Dr. Milevska Kostova, do you want to talk about this, for example?
Well, thank you, Alessandro, for the introduction. Once again, I would like to thank the organizers for the invitation to be part of this really very important topic. First webinar, I hope we have more, maybe discussing in small groups or in wider. My name is Neda Milevska, as I was introduced, and I'm representing International Alliance of Patient Organizations. At the moment, we are representing more than 300 patient organizations and alliances established in more than 72 countries. However, 35% of our membership comes from Europe. So I can speak a little bit more about Europe, but then also expanding on the other continents. So similarly to what Bianca was presenting, and we were part of that study too, we conducted another study through our Patient for Patient Safety Observatory, which is based in Switzerland. But we try to have a look at the perspective of the continuity of care and how primary healthcare played a role in the continuity of care during COVID. Similar results to what you presented, Bianca, in a slightly wider context, so globally. Maybe the difference was slightly more marginal in Europe. However, we could notice that there has been improved relationship with the primary healthcare. We could notice from the results that some of the services that could not be reached at the specialist level, they would usually be compensated through the primary healthcare level. It doesn't mean that it's a good replacement, but at least citizens were trying to reach out. As you said, also, when the doors were closed to every other health facility, pharmacies were another outlet of trying to seek medical advice. So those are the aspects of how people felt certain or uncertain about their healthcare. And this, as Alessandro mentioned, influenced on the psychological effects, not only of the lockdowns, and not only for patients, but also for the health workforce. So we were all in the same pot, if I can use that term. But in any case, I think that one thing that we can draw as patient organizations from this was that in some countries, as Dr. Bente mentioned, this challenge was attempted to become opportunity. I hope that globally we can learn that this is another challenge for us that we should turn into a much more institutionalized opportunity as per the involvement not only of patients in their individual care, but also involving civil society as a mediator and especially convener, if you wish, of the messages and of the behavior changes in population health, not only for NCDs, but also and in particular for communicable diseases, especially with the AMR, with the antimicrobial resistance. That is a particular interest of mine. And I believe that the power that the citizens and the organizations have in really diverting the river stream of how we are moving with the use of antibiotics today is huge and still unused. And I hope that we can collaborate with WHO and with other UN agencies and with governments, of course, to that end. But just to make maybe the last point of related to the first part of what we have learned from the COVID pandemic. Hopefully, we have learned that the patients, as individual observers of their own health, but also observers of the system, they can provide some useful solutions. They can really give us some insights into how we can change the healthcare systems and the societies to become more resilient. If they are part of the equation, they're more likely to have ownership over what they have to practice themselves. And after all, I think that our systems and societies exist for the citizens and for patients and for our well-being. So, in other words, from the patient perspective, I think the COVID, unfortunately, we had to learn the hard way, but was a lesson that we really need to integrate and to collaborate more if we would like to see a better care, but also a healthier population.
Thank you very much, Neda, for your insights. Professor Manfrin, taking as an example from what Neda discussed earlier, one of the key topics in the past year, but even before the COVID experience, was adherence to therapy. And I would say that it's a topic that is transversal to many therapeutic areas. And it's, I would say, a key aspect of the general care process of care therapeutic process of the patients. Would you give us some insight about this specific topic and how, especially during the COVID period, this was addressed, and what's the lesson we learned from the COVID experience?
Yes, first of all, thank you so much for having me this afternoon, and I'm very, very pleased that we are trying to tackle this issue, which is very close to my heart. I want to echo what the previous speaker talked about. It is a behavioral problem. It's not just a pharmacy problem. And I see adherence around a few concepts. The first one is simplicity of treatment, and I'm going to give you a couple of examples. And the second one is linked with a behavioral changing, not only from the patient side, from the healthcare practitioner side as well. I'll give you two simple examples, one before COVID and one during and after COVID. So we ran a very large study before COVID involving, Italy as a nation. The study involved over 2,000 patients and 1,200 were enclosed in a cluster randomized controlled trial. What we realized is that at the beginning, where we started the study, patients were taking on average 5 medications daily, 5 active ingredients on a daily basis, and the range was between 1 and 20. Then we provide an intervention to patient to improve the behavior in terms of adherence. And the number of medication taken on a daily basis went down from 5 to 4. What is interesting is that at the beginning, where people were taking on average 5 medications per day, the adherence was around 42%. When the medication were reduced on average from 5 to 4, adherence went up to 62%. So the first message is that the simplification of the treatment is an equation where less is more, particularly when we are dealing with the elderly one And I've got an example, you know, at home, my mother, for instance, you know, if we are dealing with the elderly population, we need to be very simple and very clear in terms of providing them advice and instruction if we would like that their behavior will match the required treatment. And this is one thing. Another example is the study that we are now conducting, always in Italy, and this study is involving, you know, patients with asthma and COPD. We saw the same problem. Therefore, the simplicity of the treatment is connected with poor adherence. So, and this is reinforcing the idea that as a healthcare professional, in terms of community pharmacy, hospital pharmacy, general practitioner, hospital, doctor in hospital environment, we should try to focus on communication, simplify the information that we are providing to patients, simplify the treatment if we can, because the more complex is the treatment, the more difficult it will be for the patient to deal with it. On the top of this, of course, during the COVID pandemic, what we saw was also the disconnection between the patient, the society, the healthcare practitioner, and this made things really, really worse, of course. So in some way, I believe that if we have to address adherence, we have to tackle the problem in different ways. The first one is the simplification of the treatment. The second one is communication. The third one, introduce behavioral changing model that can have a good grip on people and is not just telling them what to do, but making them aware and provide them informed decisions so they really understand the importance of taking the medication at the right time, as suggested by the doctors. But also, now that, as Bianca mentioned, we have the possibility to use digital health and digital technology, and I see this as a very, very powerful tool that could not only provide, but could also enhance the possibility to improve not only adherence to treatment, but also the way in which we can reach the patient that are possibly and potentially living in rural location. And we have quite a good example in the UK, where we have a lot of people living in rural location and where they live also in very deprived area. And these are the people that are the more vulnerable one and the one that we should really focus on as well.
Thank you very much, Professor Manfrin. Very interesting points that I would like to discuss also with Professor Galdemond. Nick, Professor Manfrin clearly highlighted how the COVID-19 pandemic disrupted the continuum of care. And how do you think this actually impacted on the interaction between patients, their formal or informal carers, and the healthcare professionals? And whether now we develop some tools or different tools that can help us in a way to fulfill this gap.
Yes, thank you very much, Alessandro, and thank you very much for the invitation. And also I echo many of the points mentioned by the previous colleagues. I think if you look to the Dutch situation, and thank you very much, Bianca, for the comprehensive presentation, I think you see a mixed picture on how patients dealt with during the pandemic with having accessibility to the healthcare system. And of course, this was compromised, partly because of the health system not able to provide sufficient support as part of the accessibility. So typically, patients with chronic conditions relying on support from primary care, social care worker, etc., was quite challenging. So we had the number of, let's say, face-to-face consultation was dropped to almost 10%. This was partly taken over by online communication. This could be WhatsApp or telephone conversation. But still, we think this had a significant impact on at least some specific groups. At the patient, from a patient perspective, there were also problems because people avoid the healthcare facilities for the risk of infections, but also, which was quite remarkable, was a sort of perception of we don't want to overburden the system. so there were also some perception aspects towards how to consume healthcare or not. So in this sort of idea on also having this accessibility and support, sorry, I have a little bit of hay fever. There was this sort of support from, let's say, the primary care and social care, had a sort of integrated care perspective, was not really supported. If you look to the sort of digital tools and solutions, most of them are very standalone, single solution focused. So in terms of collaboration among professionals, let's say the hospital, primary care, social care, etc. So also before the pandemic, there were no tools and much information exchange available. So while this was covered more on a daily basis before the pandemic in let's say, normal interaction between professionals, this was severely compromised due to normal context between professionals was really difficult. So I think there's much optimism about the uptake of digital solutions, but in reality, in the pandemic, this was merely single solutions based. And this like a sort of digital environment which can support the patients. And the same applies also for the informal networks. And so in most countries, we don't have sufficient support for community care support or informal networks as a fallback scenario to strengthen healthcare systems if the healthcare system becomes overburdened with other issues. So this is something to take in consideration. Further on the data of the Dutch situation. So we saw that even the pandemic improved some self-management aspects of patients. So I think about 20% were able to improve their self-management, did have an improvement of their health. But at the same time, you see in the more complex patients, and take, for example, the number of amputations due to diabetes, which are typically very complex patients, often with comorbidities. These have been risen in some regions to almost 30%. So apparently, there is maybe a literate, let's say, relatively capable group who actually might benefit from, let's say, awareness and information from governments or from professionals. But for specific groups, this might not apply. They actually don't benefit from all the maybe information provided. So we're still teasing out in the Netherlands about all the mechanisms and the factors during the pandemic. But it appears to be that it's also very specific for specific populations, for specific communities, socioeconomic status of people. And again, I think there's still a lot to do in providing the sort of basics on digital health. And for example, what I mentioned, even simple information exchange between a general practitioner, family doctor, and a hospital is often not possible, or a chemist in the Netherlands. So that if you are more relying on networking, integrated care, and also at the sort of social networks, there's still a lot to do. So don't be too, let's say, over enthusiastic about the uptake of WhatsApp or single solutions, but we should think about the broader strategy of digitalization. Thank you very much.
Thank you, Nick. Very interesting, and I think it's important to keep the multidisciplinary and multi-institutional perspective. To call up also Shantanu Donde from Viatris, to which I would like to ask you that despite Viatris being a pretty new company, I know that has been very active in the field of therapeutic adherence. Can you cite some example about your work in the space?
Yeah, sure, Alessandro, and thank you, ACN and Mariano, for this opportunity, because I'm really enjoying these discussions because there are so interesting viewpoints, and we are not only enlisting the barriers, but also very solution focused. I can see from the other speakers that, okay, how we are looking forward. And Alessandro, as you know, yes, Viatris is a relatively new company. We have just completed 2 years. However, we are coming from two rich legacies of Legacy Mylan and Legacy Upjohn coming together. And we had, in fact, incidentally had a very interesting multi-stakeholder roundtable just before the pandemic, where we partnered with European Innovation Partnership on Active and Healthy Aging. And the core theme there was adherence, along with the integrated care and loss of functional ability. So we had identified a number of interesting projects in different countries. And just as the pandemic started, these projects started rolling out in those countries. I will just name a few of them, which are on different levels and which are creating impact. One was in a very interesting one in Belgium, where we saw that there are a lot of elderly patients on polypharmacy who are really not having good medication adherence, especially those who are hospitalized. They have to be re-hospitalized just because they have not been adherent on the medications and due to side effects. So there was a very interesting study which we are supporting, and it's ongoing, on how to prevent re-hospitalization of the patients by providing the right therapeutic interventions at the pharmacist levels, and to ensure, and we are looking at, okay, for those who are getting the right interventions, what is the rate, how it is decreased, and so on. So we will definitely happy to share the results as they come in. The second one was interesting in Greece, where the earlier one was Professor Horst Tournoy from Belgium. In Greece, Professor Fantopoulos did an amazing study, and again, a lot around the behavioral insights, which I think Bente, Neda, and everyone mentioned how important it is to look at those behavioral insights of the patients. So that study has brought out, okay, what are those really determinants which are affecting the medication adherence? And there is a nice paper published by Professor. And the third one I want to again refer to is, I think Andrea mentioned about the importance of the simplicity of the risk communication. So we did a very interesting project in UK where simplifying the cardiovascular risk communication, we developed, supported a tool and tried to go to the communities which were more disadvantaged and were not getting the right health information, to see that, okay, how does this simplifying the risk communication helps in improving the adherence. So these three were the important projects I wanted to highlight. And second is, Bianca presented very interesting results, and we were very happy to partner with ACN to carry out that survey. And there are very interesting results. Some of them are definitely validating what we have been thinking. So what we have been presuming are the barriers, they were confirmed. But there were two aspects which I want to highlight, Alessandro, and that is, one is the dose dispensing. This is one of the aspects where, whether it is a manual or automatic, the awareness is very low. And we found that only 40% of the patients were aware of the concept itself. And those who are aware, they found that more than 50% benefited in their adherence due to this concept. And second concept I wanted to mention here is value-added medicine. I think this is very important in terms of meeting the unmet needs of the patient, because repurposing the medicines which patients are used to, it can help to improve their quality of life. It goes in a long way to also increase the medication adherence. And that's why we need to look at these concepts also going forward. And lastly, the digital tools. I think we all agree that digital has a long way to play, but we had a very interesting discussion with some patient stakeholders, and we found that there is a gap there, because the digital tools which are really found valuable by the healthcare professionals may not have the same value from the patient perspectives. So we need to include them while we are developing those tools. We need to look at the insights and try to really be more patient-centric and patient-focused to ensure that we are providing them with the right solutions. But a lot of interesting papers published during this time, Alessandro, and happy that you are also part of some of them, We had multi-stakeholder partnerships, which Nick was there, and ACN, of course. So I think these are very critical elements. And like my fellow members also highlighted, I think there is a long way to go, because medication adherence before, during COVID and after, the needle has not moved. We are still below 50%. And I think there is a lot that we can do to achieve this. Thank you.
Thank you very much, Shantanu, for adding a further piece to the discussion. Very important. I will start now with the second round of questions, starting again from Dr. Mikkelsen. Dr. Mikkelsen, what's next then? And how different institutions, both public and private, can collaborate to deliver a positive change that nowadays is necessary, is not more an option, into the care model of chronic disease, including addressing the issue of adherence?
Thank you very much, and thank you for very interesting contributions from my fellow panelists. You always learn a lot by being a panelist. That's great. So I think to address adherence is really a multifactorial, multidimensional thing, and I think that sometimes the sort of the way to try to simplify just talking about a sort of one pill solution doesn't really help so much. If we just look into the pure fact, which we were discussing in the former session as well, that the health system doesn't really respond to the chronic diseases. The primary health care is not developed to the extent that is needed. And I would like to add the lack of financial protection is, of course, a huge factor when we talk about adherence. I saw figures from the WHO region of Euro region, and I cannot exactly remember, but it was in the range of 80% of the cost was actually, out-of-pocket cost for chronic diseases. So of course, if you have to pay for your own medicines and for your own treatment, if it's not a social insurance scheme, that's absolutely a place to start. So I think we need to sort of look at all the different dimensions. Personally, I have a hope that we should be able to learn from what came out of COVID, and it was mentioned now by several of the panelists, but things like novel prescribing approaches, self-care. We were talking about task shifting, role delegation, but also integration of several services into a single visit, and really making real the sort of the person-centered approach. I think all of this is important. I want to add that you mentioned, Shantanu, the hypertension situation. And of course, all of you on this line know that hypertension is the main cause of death in the world. So if you look at all figures of deaths, global deaths, you will find that stroke and cardiovascular emergencies is number one and number two. So these represent the main cause of death in the world. And if we then think about how difficult it should or is be to diagnose and screen and treat and control hypertension, it's actually a moral problem, because at the moment we have only 50% of people in the world diagnosed with hypertension, and out of these 50% of those who actually have hypertension, only 40% is managed, and only 20% globally is under control. And what does it take to diagnose hypertension? It actually takes a manometer. It doesn't even require a doctor. It could be a trained community worker. And the medicines we are talking about here is off patent, the most cheap medicines in the world, which unfortunately ends up being quite expensive when it comes to the patients because of all the markups in the world. So what we have done here is to try to learn from HIV. So we have provided a protocol-based treatment with 2 different protocols that can be chosen by the lowest income countries and the low and middle income countries, but it's actually quite useful for all countries. And of course, this is not the full answer to the thing, but at least it could be a trigger, a kind of a model case. So if we start with a protocol like this, we need to train, we need to provide the medicines, we need to sort of look into what kind of healthcare system is needed to do this. So I believe that the combination of a full sort of multifactorial, multidimensional view combined with some trigger actions, and to add, the most important is the co-creation with the patient population. So my last on this one is that I was very pleased that we were able to launch health literacy documents this year. Call it health literacy, call it behavioral insight. I don't care about the name of the animal, but I think what is common in all of this is that we have to listen to those who are affected, those who actually do the work, and we also have to use all the data we can find to really pinpoint those actions that support most people and start from there. So I think that's my comment in this round. Thanks.
Thank you very much, Dr. Mikkelsen. And we are pretty aware of the effect of COVID, Neda, but we are also looking at some sort of phenomena which is extremely interesting and extremely dangerous, which is long COVID, that we're seeing is actually including itself in already very complex situation of non-communicable disease and chronic disease. So it's kind of 2 phenomena that are merging each other in a dramatic way. And this is dramatically affecting the way we take care of patients, of the general chronic care model, but also the impact is on the socioeconomic aspect of the society. What do you think about it? Do you have some information that you can share with us?
Well, thank you, Alessandro. Sorry, Dr. Bente? You wanted to say something?
No, thank you.
Okay. Thank you, Alessandro. I really think that long COVID is another a challenge or another stepping stone that we are faced with as a global community now already. Many of the things that have been said, they actually really can be applied to addressing the long COVID, I would say. In another way, as you said, those are the communicable disease turning into a chronic condition that is no longer even communicable, it becomes a non-communicable. And here, not only therapeutic adherence, I mean, at the moment, we don't have any treatment. We don't really know what it is. We just have some description. We just have accounts from patients, same as what we felt with the COVID at the beginning of the pandemic, except that one was a really fast spreading, and this one is a very latent and very silent present among the population, and we are still not even aware of the numbers or aware of the full consequences. And that is why I think that what was said in the beginning or throughout the first round of discussions, I think it is very important that we use the digital tools mentioned by Nick and I think Shantanu, that they can really help us to map what is going on, to really use the big data to understand the long COVID, but also what was mentioned by Bente and by Andrea as well, that involving patients and those who have suffered or those who are something we want to call expert patients. Those can help us not only identify what is going on or help us in the research of how to better cope with long COVID, but also it can help us for other diseases, for other chronic diseases, because no one knows more their own condition than someone who lives with it for 24 hours and really have observed experiences. And those observations during their experience, in fact. So those who are even for hypertension or those in any chronic disease, I just don't want to mention diabetes, we heard earlier, even HIV, those who have lived through that experience, they can far better than any one of us in the healthcare system. Personally, I'm a pharmacist, so that's why I identify with the healthcare professional as well. So anyone with the lived experiences can know and advise better the patient of the quality of life, of how they can adhere to the to manage their disease, to take the therapy properly, because it is a fact from one of our earlier studies that a patient with a sickle cell anemia, we had one example through interviews. He mentioned that he had spent 80,000 times more on caring for himself at home than he had interaction with the healthcare system. So you can imagine the amount of information and knowledge he knows about managing his own disease. And sickle cell anemia is really one of those very silent, very unfair diseases where you end up with a stroke or out of nowhere simply because your blood is not capable enough, or the medications are not sufficient enough to help you even notice some of the early signs. So in that sense, it becomes a chronic disease that can acutize very easily. Therefore, we believe that involving expert patients in not only long COVID is just an example, in any of the chronic diseases, can help us not only reduce the burden on the healthcare system, but also sort of have an expanded safety net or expanded network of advice. And I strongly believe that digital solutions can help us, and sharing information can help us, but the human contact can never be replaced, I believe. And in this sense, having patients more in 3 areas. One is maybe research, where they can help with their experiences, and it's more a society or level. And then on the individual level, expert patients may be difficult to institutionalize. Maybe that is a challenge of our future resilient systems, of how we integrate the expert patients into the systems to help educate and train new patients, or teach them how to prevent specific conditions or complications with their own disease. So those are the 2 areas where we believe long COVID can help us in the next years to find ways to create models for patients to be involved in other areas as well. Thank you.
Thank you very much, Neda. Professor Manfrin, one of the key drivers in addressing complex issues, including adherence, is communication. How we can actually facilitate the opportunity to improve communication among institutions, healthcare professionals, and people to ultimately improve the health outcomes?
Thank you for this question, which is really, really close to my heart. Is also related to something that we are doing. I'm a very simple person, so I tend to use example to clarify. I'm not a philosopher, so I'm a very ground worker person. So I'll give you a few examples. So the first one is, for instance, we are living in a more and more multi-ethnic and multi-speaking society. So we are people speaking many languages, but most of the time our parents, they don't speak all the language they will speak so far. So there are countries where community pharmacies and pharmacists can issue the instruction label in different languages. An example is Switzerland. They issue the instruction label in Italian, German, French, and English. So that is one way to reach the patient and to improve communication. That's the first thing that we can do. And this could be done easily everywhere. It's just a matter of software. So this is the first thing to do. The second one, I'm going to tell you about a study that we are conducting now. So this is the second study, and it's called idea density. I don't know if you never come across. The concept of idea density is to simplify the information that we are providing. So we are testing this. We tested this concept in an observational study and now in a large randomized controlled trial. And we use students as the guinea pig for this study. But what we realize is that, when we are simplifying the communication, and in this case, the question that we are asking the student that they do not have English as their first language, they improve their understanding and they improve their score. So now the question is, we are thinking of translating this one into dementia patient, for instance, where information retention is a huge problem, but this can be translated in a wider population. If we think about people are getting older and older, therefore retention of information and understanding and processing of this information could become a challenge. Therefore, this could be another option in which we can improve communication between healthcare practitioner and the patient. With regards to the institutional and organization, I think that we need to learn, and this is a cultural change, we need to learn how to write information in a simple way. We tend to write very complex stuff that we don't understand at the end, because most of the time I'm asking people, can you summarize in 2 sentences? They can't. Therefore, if I'm a patient, I'm a real fan of information in a nutshell, but very clear that everybody can understand. And so if we would like to improve our interaction, this is a cultural challenge where everybody, each single organization, each single person, each single head of department should in some way engage with people and beg them, I would say, to make sure that they use lay terminology. Because, for instance, we are all working with different projects, and we are working most of the time with the multidisciplinary teams, and we don't understand each other because we use too much jargon. So again, if we would like to make sure that our patient, our partners, our stakeholders, they really have a clear understanding of what we have to say, what we would like to do, and what we would like to achieve, I think the communication can play a huge factor in the equation. Absolutely. And how to enhance it? Well, simplifying the concept and making sure that we can explain complex information, complex structure, or complex concept in a very simple way. And most of the time in our study, what we realize is that sometimes patients are complaining by the fact that the healthcare practitioner, they do not have time. But sometimes they told us that they can understand what they have been told. So they say yes upfront because they don't want to upset the healthcare practitioner. When they leave, they can remember what they should do. So again, as I said, I'm a very practical person. Therefore, I look at the practicality of the side.
Thank you very much, Professor Manfredi. Nick, talking about examples and talking about the opportunity to use digital tools to address the issue of interaction between patient and healthcare professional. Do you want to make some example? Do you want to tell us about your experience in that, and how in particular you manage with complications during pandemics?
Yes, thank you very much. Well, I think so there are many good examples on how to support community-oriented, patient-centered care. And we do already know what is needed to have more resilient healthcare systems, which are more effective and more focusing on prevention. So rather than in a lot of discussion with my academic colleagues is they accumulating evidence and new reports, etc. I think we are at a point in time where we see where our healthcare systems are really under pressure, for all kind of reasons, and the pandemic accelerated this. So I think the priority on implementation and making things happen is really critical. And when it comes to self-management, therapy adherence, better focus on prevention, the community is central. And there's where the setting where you can make the difference, whether it's primary prevention, secondary prevention with patient at risk, about affiliating all kind of problems with people with chronic condition and complications. So this community focus, where you are dealing with social networks, about the setting in a community, in a neighborhood, with all the actors, might be employers, it might be schools. We should implement the things we know you should have in place in order to make strategies more effective and at the same time more personalized, but also there. It starts often with the sort of how people collaborate, how they communicate. As what Neda and Bente also explaining, and also Andrea, it's also how you engage people and the patient in this process in order to make them that they adapt to a sort of solution, and how you think about reorganizing processes, services of care for a particular community or population. You have to engage them, and technology can help, but it should not be the starting point. The starting point is the context, are the needs of the people, and the involvement of the actors. So in the last 10, 15 years, we've seen many good practices doing exactly this. Sometimes it was more focusing on aging, sometimes it was more on other minorities, Romas, or so we have many examples on how it could work. In my experience, working also in Brazil and China, it's very much the same. They're dealing with the similar issues, whether it's a favela, and where you have to build a sort of network of people and different disciplines, and the primary care and healthcare centers are quite central in this. But you have the same sort of ingredients. It might be a bit tailored, but and the same applies also in China. I think China is a bit different because their primary care is almost absent. Although you have some, let's say, barefoot doctors, which is a sort of primary care sort of approach. But there you saw the digital solutions at also the digital platforms as an alternative to access primary care was relatively successful. It was very much focusing on prescription of medication, but as a concept to have a more easy access in parallel to physical access. I think that this is also what we can learn from countries like China, and as well as there are many other countries on continents who could provide good examples. But yeah, I think we should set priorities on implementation and action. So we know enough. We have enough evidence in literacy, in primary care concepts, in sort of digital application, how they could work, but in a sort of coherent approach that is now vital for governments. And also there, we could benefit from better collaboration, and also from European level or international level, European level, country level, and local level on how this might work in alignment with each other. So there is where I see often typical difference, the challenges, and how we align all these elements in order that we can be effective at a local level. So it's not a very simple task, but I think we can be confident because we know a lot. We have many good practices, and hopefully we have now the momentum after the pandemic to work more effectively together.
Thank you very much, Nick, for the very important perspective. I would like to pass by Shantanu now. Shantanu, how important do you think are a multi-stakeholder partnership when it comes to address and surmount such challenges?
Yeah, thanks, Alessandro. Again, a very interesting round where I saw patient engagement and an informed patient. I think these are two very key perspectives along with the multi-stakeholder partnerships. So, in fact, multi-stakeholder partnership is something which has given us good accolades in the recent past. because we were nominated for the Life Science Excellence Award for our best patient advocacy program of the year during the pandemic. So this really validates, okay, the things that we are doing have been recognized by the third party, and we partnered with our Italian agency, Oliva, and we were also nominated for innovative response in the COVID pandemic. So we were nominated by CPHI Pharma Award. So this gave a lot of boost and confidence to the team that the efforts that we are putting in towards the partnerships is really bearing fruit. And there are two really interesting partnerships that we did. One was the NCD Summit, which was bringing together all the stakeholders and including not only the healthcare professionals, but also the informal caregivers. And I think someone mentioned the importance that they have achieved during the COVID pandemic. So the formal and the informal caregivers also play an important part. We really need to ensure that we are not missing out on any key partner when we are developing these strategies and we are driving some of those initiatives. Likewise, I think our main thrust was around, again, the patient roundtable. So we brought the advocacies and the patient advocates together on a roundtable to understand their insights. And as you know, this pandemic, there are a lot of learnings, but probably if we don't implement and the right projects with the right partners, I think we are surely this one is not the last one, but we will be more equipped to deal with the future kind of pandemics if we really take the steps and bring the patients together. And just the last point, Alessandro, is we saw that patient engagement is very key. Experts in a lot of things like Neda mentioned, Bente. But just last week, I initiated something which is not a little different, but patient role in the health technology assessments for different diseases. We see that it's very important. However, we looked at a lot of literature and we saw there is so much gap there that we talk of patient centricity, but when it comes to deriving their insights where it really matters, it's still not there. So it was a very interesting way in how we could bring in patient angle into different things that we want to do. But as I saw from the other panelists, I think we all agree that yes, it is the key. And to your address, only we as a multi-stakeholder partners, if we come together, we can really surmount any challenge that comes up in the future.
Oh, thank you very much, Shantanu. I don't know if there are questions from the audience. Maybe we can address them in a minute or two, but probably not. No question from the audience. So there was such an interesting discussion. And I would say that many relevant points were raised about the opportunity, in a way, to learn for sure from the COVID experience, but also somehow to develop new and more patient-centric approaches to address the chronic care model. What really emerged from our conversation is that the role of civic association is central to deliver the perspective of the individuals and to address their clinical needs. The development of digital tools can support the interaction of patient healthcare professional, and we need a continuous monitor system from real-world data to develop appropriate and evidence-based policy. And now the challenge of long COVID will prompt us to deliver multidimensional approaches to, in a way, manage the chronicity in an appropriate and a cost-effective manner. Communication is pivotal to align lay people, clinician, institution toward a common goal that is for sure improving outcomes and the quality of life individuals. We should really build from the experience of this project and give continuity to this interaction to ensure that the priorities are set and new perspectives are grounded into real-world approaches and clinical practice. I was wondering if Mariano want to wrap up the meeting with some closing remarks.
Thanks, Alessandro. Thank you very much for a very rich debate, a lot of suggestion. I just want to put out to highlight one point more, that is starting from what we listen a lot, for instance, the statement of the health commissioner. We are going to be seeing the effect of COVID-19 in the years to come. Extremely true, but we can probably try to translate this message in the sense that we need to be, each one of us, more than even more responsible towards more resilient healthcare system, towards European Health Union. And we try to better identify in which way we can be more responsible, for instance, at the institutional level, at all levels, starting from the European level. The next European election, if you want to be elected, what should be your commitment towards more resilient health system? When we plan at the national level, the national plan on chronicity, today we talk about the role of therapeutic adherence. So please let us know what should be this role in the national plan on chronicity. In Italy, someone want to renounce to e-prescription that was a lot increased during the pandemic, and one of the advancement, the lesson learned that we can probably take in mind some advancement. So I think that also the role of the private sector or the others that are now, there is a new concept, the global health, very well known by the WHO, but probably not too much customized and among the population. And so, as someone also discussed about the point of health literacy, who is in charge to provide health literacy for the citizens? How can we increase consciousness among the population about some topics that are linked with the correct behavior? Today, talking about therapeutic adherence, but we can probably advance a new concept as the discriminants of health, the global health, because my behavior, my decision could be an effect, a positive or negative, to reduce or to emphasize the impact of new pandemic, etc. So there are a lot of questions. From my perspective, one of the messages of the survey, it was also to highlight the importance of a synergic approach of patient advocacy group, citizens organization, to integrate, to support, to complement institutional and not institutional activities to address the primary needs of chronic patients. And in coherence with this, we have decided for this year to realize a lot of training sessions. And I'd like to invite, to take note, please, for our next initiative plan, 14th of March. That is a training tailored, as always, for us leader of citizens and patient advocacy groups, entitled Improving Health Literacy and Protecting the Value of Access to Care for Better Public and Patient Involvement in Mitigating COVID, but also to increase consciousness about global health. So this is a fixed appointment. It's also our way to be coherent with some message that we have highlighted in today's initiative. Finally, as always, I have my list of knowledge. So thanks again to all the panelists, the moderator, our audience, and the patient advocacy groups involved in the survey, connected with us. There I have founded colleagues and friends from Malta, the Netherlands, Slovenia, Austria, Belgium, a part of Italy, of course, that I want to thank. The list of these patient advocacy groups will be published shortly in our website, together with all the content of this initiative, starting with the research shown by Bianca. At the same time, please let me remember that today's webinar is part of the homonym European project Therapeutic Adherence during the COVID-19 pandemic across Europe, impact experience and perspective from PAGs and relevant stakeholders from the second year, supported by Beatrice, which I thank for the trust. At the same time, please let me thank our two media partners, Health Europe and Policy and Procurement in Healthcare, also connected with us today. As always, please let me thank the staff, my colleagues. So Bianca, first of all, Daniela, our event manager, Elisa and Marianna, our communication office. I think that we can close here at this webinar. I thank you again for the attention. See you, and we keep in touch for next initiative. Goodbye from Rome. Arrivederci.
Thank you all. Ciao.
Thank you all.
Thank you. Bye.
Thank you.
Bye.
Grazie. Bye. Bye. Bye.
Yeah.